So first, let's just start by having you introduce yourselves. This is a really exciting talk we're doing here, and it's all for World Mental Health Day. And I think it's very exciting for Mindset Health that we have both of you on the scientific advisory board as leaders in this field, and having you be able to speak today to some of our users is exciting. So if you could just introduce yourselves, and then we'll hop into questions.
After you, Simone.
Okay. Hello, everyone. My name's Dr. Simone Peters. I'm the founder and the managing director of a multidisciplinary gastroenterology clinic here in Melbourne, Australia, called the Mind and Gut Clinic. And when I'm not busy in my own clinic, I work at Monash University in a research capacity, and I'm also the head of clinical content at Nerva. And as Claire mentioned, I work as a scientific advisor to Mindset Health.
Okay. And I am Dr. Michael Yapko. I'm a clinical psychologist in Southern California. And I have been a clinical psychologist practicing now for almost 40 years and have specialized in the treatment of major depression, the most common mood disorder on the planet, and have really developed hypnosis as a treatment tool for addressing mood disorders. I am the author of 16 books. I have been advancing these techniques, and they've been recognized by my international colleagues. I've been invited to teach in more than 30 countries across 6 continents, and that's me.
Awesome, thank you. I think one of the questions we're going to start off with, we'll get more into the nitty gritty of what hypnosis and hypnotherapy are. But I think what's exciting for our users is hearing how you got into hypnosis in the first place, because it is such a niche. And I'd love to hear the story of how you got into hypnosis. Michael, you could start, and then we'll go to Simone.
Well, when I was 19 years old, I was an undergraduate student at the University of Michigan studying psychology. And I attended a 2-day workshop on hypnosis, knowing nothing about it at all, literally nothing other than what you see in silly stage shows and movies and television programs. And so I was interested in the clinical side of it. And so during the 2-day workshop, the workshop leader conducted a clinical demonstration that had a profound impact on me. It was with a woman who had been in a very serious car accident 3 years earlier. She had multiple bones broken and organs lacerated. It was just a really serious thing. And she had had multiple surgeries. She had mostly recovered, but she continued to have a very severe pain, chronic pain in her leg that the doctors basically told her that she was just going to have to live with it. And so as she's telling her story about all the terrible impact that this injury has had on her life, I remember vividly thinking to myself, what can this guy possibly say to her that's going to make any kind of difference at all? Well, he started doing his induction with her, just a general relaxation kind of a process, then started giving her a bunch of suggestions that to me sounded really strange about how her pain could turn into a dark viscous liquid and flow down her leg and out of her shoe and onto the floor, where it would just be a harmless puddle of pain. And I had no understanding of that. It just sounded weird to me, frankly. But looking at her, it was clear that something major had happened. And when she sat up and opened her eyes after the session was over, she literally started crying before she said, "This is the first time in 3 years I've been pain-free." And literally in that moment, I thought to myself, I have got to learn how to do this. And so now, literally almost 50 years ago, I have been studying hypnosis, writing about hypnosis, researching hypnosis virtually every day of my professional life. And it has just demonstrated itself over and over and over again how valuable a tool it really is in treatment.
It's amazing.
So I had a little bit of a different introduction to hypnosis, I suppose. So I was doing my PhD some 12 years ago now with Monash University, and my PhD topic was actually completely unrelated to hypnosis. Well, it was meant to be unrelated to hypnosis. So we were doing fancy things with isolating gluten proteins in people who have what we call non-celiac gluten sensitivity. So people who essentially have problems eating gluten but don't have celiac disease. And somewhere along the line, my project became somewhat hijacked by hypnotherapy because we started to become very aware of how hypnotherapy was being used in patients who had irritable bowel syndrome in a group in the UK. And this group was headed by Professor Peter Warble and was known then and is still known today as the South Manchester Functional Bowel Service. And we became aware of this work because they were showing really great results in terms of managing these physical symptoms in patients who presented with irritable bowel syndrome. And at the time, it was the only group around the world that was doing this kind of work. And so we wanted to try and see if we could reproduce the findings that they were uncovering over in this group. And we also wanted to see if we could compare how effective hypnotherapy was to some of the other management strategies that we were using within our clinic. And so what was meant to be a very small pilot study turned into a very large randomized control trial. And essentially what we found was that our work mimicked the work of the group in the UK, and that certainly we found that all of our patients, or certainly the vast majority of our patients, had a really great response to hypnotherapy in terms of a reduction in their physical symptoms. And really surprisingly to us, I think, was that these improvements were maintained in the long term. So one of the really tricky things we have in terms of managing irritable bowel syndrome is that we're really good at getting people better initially. We're not so good at keeping people better in the long term. And what we found with the hypnotherapy was that not only did people respond initially, but we were able to maintain that level of improvement in the long term. And so I guess at that point, I became very interested in hypnotherapy and the utilisation of hypnotherapy in patients who have sort of what we call disorders of gut-brain interaction, which I think we'll probably get into in a little bit more detail later on. But yeah, needless to say, I've become somewhat obsessed with hypnotherapy since that time.
Well, here's a little piece of trivia for you, Simone. I did the hypnosis trainings for the people at Manchester Hospital. And I was there quite a few times with Peter and his group, Wendy Gonçalves-Corrali. And it was really innovative work that they were doing. And it's fabulous that you picked up on it and expanded it.
Yeah. Yeah, they're an amazing group. They certainly welcomed me with open arms when I turned up on their doorstep as a young PhD student, asking for lots and lots of help with lots and lots of questions.
Very good.
How is it that you both feel working in a field that has been so stigmatized, and ideally it's something that we're in Mindset Health, we're certainly trying to break down that stigma, but how have you felt over your careers that working with something that people might not initially respond to or might not initially want to take on board as something that they want to partake in?
You want to address that, Simone? I'll
Sure.
offer my comments.
I think I think you're right. There's a high level of skepticism that is often associated with utilising hypnotherapy. And if I think just about, how I've used hypnotherapy in the last 12 years and how the medical community has responded to this as a management strategy, you've seen a really notable shift over time in terms of how people view this as a therapeutic model. And I guess the thing in my space is that in the medical community, our currency is publications in peer-reviewed, good quality medical journals. And I think how we've built a really solid reputation and how we have managed this high level of skepticism is through really good quality research. But you're right, it is a challenge. And often when I meet a patient for the first time, one of the very first conversations that we have is around the validation of what it is that we're doing. But I think that will change. I think that's the same, in any industry or with anything new or with anything cutting edge. if we think about, clearly I work in the gastroenterology space, but if we think about the use of a low FODMAP diet as an example for irritable bowel syndrome, 10 years ago, that was completely unheard of. And there was a high level of skepticism that was, around the use of a dietary intervention for managing irritable bowel syndrome. But now it's used as a primary dietary therapy. It's recognised all around the world. People don't even blink an eyelid when they tell you that they're on a low FODMAP diet these days. So education, good quality evidence, support, professional encouragement, these are all really important things to reduce the stigma.
Yeah. I think Simone's absolutely right about that. I'd add a few things. Certainly most people's exposure to hypnosis is only in the Hollywood context, whether it's stage hypnosis or in movies or television where hypnosis is made the culprit for antisocial behavior. This person was hypnotized to go rob a bank, kind of a thing. And so, people often dismiss it. There is a stigma attached to it. But the funny part is that people respond to the label hypnosis, but they don't respond to the experience of it. So if you say hypnosis, people go, I'm not sure about that. You say, well, when people are very focused and people are very relaxed, they go, yeah, I can get into that. And so when you describe the actual process to them, rather than just use the label, that stigma evaporates. People understand, whether they're clinicians or lay people, that people learn more easily when they're focused, when they're relaxed. The single most compelling reasons to want to integrate hypnosis into any treatment plan, how much of treatment is about education, how much of treatment is about helping people learn about what data might be available, or learn what applications have been developed. And most people don't really review journals and read the science side of it. That's great for training clinicians. But for the average person who's seeking help, when you start to describe the process of it, that's when the skepticism subsides and people start to appreciate, yeah, I understand. This is a learning process. This is a training process. This is a way of building a frame of mind that helps me accomplish the things that I'm here to accomplish. And that's really the challenge in hypnosis. And probably the best way to think about it is it's about building frames of mind. How do I help people get into the way of thinking that helps them accomplish whatever they came to therapy to accomplish?
Yeah, it's pretty amazing. And I think you sort of are leading in this direction. So my next question is about how hypnotherapy works and how hypnosis and hypnosis can affect the mind-body relationship and actually make physical change in patients. I'm wondering if you could dive into that a little bit, Dr. Yapko.
The question of how hypnosis works has been asked forever. And there's something about this quality of experience. It has yet to be measured. It hasn't been measured electrically. It hasn't been measured chemically. You can't look at a brain scan and say that person's in hypnosis with any degree of reliability. And yet clearly something changes, that when somebody gets absorbed in this experience and detaches from the external reality and get absorbed internally in their own thought processes, imagery, the suggestions that you're providing them, things change. And it's absolutely fascinating how the mind influences the brain. The studies that have been done, just to cite one recent one that was really interesting, I came across out of Norway, where they were doing a study involving pupillometrics, measuring the pupil of the eye in response to light changes. Well, as most people know, when light is brighter, the pupil of the eye constricts. When light is dimmer, the pupil of the eye expands, dilates. And so what they did was they lightened the light, dimmed the light, measured how much the person's pupils dilated or constricted, not in hypnosis. Then they did a focusing exercise, an induction. And then they said, okay, now we're going to brighten the light again. Now we're going to dim the light again. And they measured the size of the pupil as it changed again. The only thing was they never brightened or dimmed the light in actuality. the person responded to the suggested reality instead of the actual reality. And there have been many studies along those same lines of how people can get absorbed in a style of thinking. Well, the things that you think about have obviously a physical effect. You think about the things that are upsetting to you, you'll notice the tension in your body. The exact mechanisms for how that happened have yet to be described, but it's well understood that you can have the thought as you sit on an airplane that this plane could crash, and all of a sudden you're hyperventilating and getting tense and anxious. And it goes two ways. Your mind influences your body influences your mind. The exact physio pathways, a lot to be learned in that regard. But the ability to use that quality of absorption and suggestion to influence bodily processes, just as I described in my story about how I got exposed to hypnosis through pain management suggestions. Really interesting.
Simone, I'm wondering if you could answer this question as well, just from the perspective of being a clinician working with IBS patients.
So I think, Michael is right. When we have attempted to look at what we sort of call mechanisms of action, what exactly are we manipulating when we provide this sort of direct suggestion to what we call this subconscious part of the mind, which is obviously what we're trying to do when we are providing hypnotherapy. And when we look at patients who have irritable bowel syndrome and we look at their physical presentation, often there are a couple of characteristics which are frequently observed. So one is this idea around what we would call somebody's motility. So the time it takes from when they eat something to when they pass that same thing at the other end. And we know that in people who present with irritable bowel syndrome, they have alterations in what we call their motility. So things are moving through too quickly, or things are moving through too slowly, or it might be that it's a little bit of a combination of the two. So they're presenting with symptoms of diarrhea or constipation, or like I said, a little bit of both. They also present with what we call visceral hypersensitivity, which is just an incredibly fancy way of us saying that all of the nerves that are in their tummy are just much more sensitive than what we want them to be. And so again, this presents in symptoms like abdominal pain and bloating, discomfort. And so we've done these fancy studies where what we're trying to do is essentially determine what it is that we're altering when we're providing this direct suggestion to that subconscious part of the mind. So we've done these studies where we essentially get our patients to swallow these little capsules, and we can trace these little capsules in terms of how long they take to move through the digestive tract. And what we've been able to show is that we can normalize somebody's motility after a course of hypnotherapy. So we can slow down the movement of these little cameras, or we can increase the movement of these little cameras based on the suggestions that we provide. The other thing that we've done, and this sounds terrible, and we're entirely grateful for our poor participants who we put through these experiments, but essentially what we've also done is we've blown balloons up inside people's bottoms, and we get them to recognise at what point they describe pain. Now, obviously, we do this because we can access the nerves in somebody's bottom, but it's obviously difficult to access the nerves in other parts of the gastrointestinal tract. And what we know that is in people who have irritable bowel, you can only blow that balloon up to a very small degree before that they'll tell us that they're in quite notable pain. Whereas somebody who doesn't have irritable bowel, you can blow that balloon up to a much larger degree before they would describe the same experience of pain. And again, following hypnotherapy, so following that direct suggestion, we've been able to show that we can normalize that response. So what we mean by that is that in people who have irritable bowel, after a course of hypnotherapy, we could blow that balloon up to the same degree of our healthy controls before that they would describe the pain. So in other words, what we've been able to show is that we're having a physical effect on people's bodies via hypnosis. But how we are doing that, what the exact mechanism is behind that, we have absolutely no idea.
It's a mystery that we would like to be able to solve, certainly. But can you talk a little bit about the difference between hypnotherapy and meditation, or hypnotherapy and other psychological therapies?
So the way that I usually describe it, and Michael, you might have something that you want to add here, but often to my patients, I describe it as being very similar to guided meditation in the context that certainly when we use hypnotherapy as a way of managing irritable bowel syndrome, we do what's called an induction. So we get the patient into a very nice, relaxed state, and we use lots of different metaphors in order to help to get them to that point. And then once they're in that really nice, relaxed state, we make suggestions, like I said before, to the subconscious part of the mind. So the best way of describing it to a patient is by telling them it's very similar to guided meditation in the context that they're going to be presented with a story. The thing that makes it hypnosis as opposed to meditation, as an example, is that when they're in that really nice, relaxed state, we provide that suggestion to the subconscious part of the mind. So I would imagine that often people are in a hypnotic state when they do meditation, but it's not hypnosis if there's no direct suggestion.
Viewers might be interested in that I wrote a book called Mindfulness and Hypnosis, and detailed where they overlap and where they differ. Any approach, whether it's mindfulness, guided meditation, guided imagery, visualization, anything experiential like that involves focusing one's attention, is going to have hypnotic elements that are a part of it. Where they differ is in how they're applied. It's very different. If you look at what mindfulness has really historically been about, it's been about enlightenment, higher consciousness, developing greater perspectives about acceptance and compassion and those kinds of things. And what hypnosis is about, of course, is targeting specific problems and providing solutions to them, helping people develop the resources. So hypnosis is a much more goal-oriented kind of a process. And when you listen to mindfulness experts, they will often describe meditation as attention without intention. And the way that I would characterize hypnosis is as attention with intention. Hypnosis is unapologetically a goal-oriented process, whether it's to reduce the symptoms of IBS or pain or depression or anxiety or anything else. You wouldn't conduct a hypnosis session typically to increase somebody's level of compassion. You might if this person's problem was a lack of empathy, but more typically you're addressing the kinds of emotional and physical symptoms and striving towards some kind of resolution to empower people to gain access to internal resources that are latent, resources they didn't even know they had. So when I was telling this, the earlier example of the woman with the pain, until she had that hypnotic experience, how would she possibly have known that she was capable of pain management? Until she went into that volunteer demonstration, there's no way she would have known that she had that quality of hypnotizability, hypnotic responsiveness. And that's really an important distinction, that when you use that focus in a very intentional way to produce particular results, now you're in the domain of hypnosis.
And how do you decide if a patient is right for hypnosis? Because I know there's obviously other psychological therapies, and hypnosis has a unique set of qualities. And how do you decide when a patient comes into you and sees you that hypnosis is the right strategy for that patient?
Want to take that?
Yeah, sure. So I think, look, generally speaking, hypnotherapy can be applied in most patients. In saying that there are some patients where it's not necessarily appropriate, and often these are in patients who have quite notable psychological comorbidities. An example of that might be somebody who has a notable trauma history, or somebody who might be in an altered state of consciousness already. So somebody with psychosis, say, for example. But, in people who don't have psychological comorbidities, who are otherwise fit and well. We know that probably about 80% of people, certainly in the patient population that we manage, will respond really favourably to hypnotherapy. So it can certainly be applied in the vast majority of patients, but obviously an assessment needs to be done by the clinician to ensure that we're not going to run into any difficulties in terms of putting that person into an altered state of consciousness.
Yeah. This is a great question because it speaks to one of the ongoing issues in the field. One of the very few things that everybody agrees on is that people differ in their hypnotic abilities. And so when you start a hypnosis session with somebody, you really don't know what their capacity is going to be. For me, that's one of the joys of working with people, is helping people discover these abilities that they didn't even know they had and how to use them. So there are people who have developed standardized tests to determine whether someone is responsive and to what degree. But what it really turns out is that all these tests measure is the person's response to the test, how they're going to respond in actual clinical practice when you're offering them suggestions that are to their benefit. And, the reality is we don't treat diagnostic categories, we treat people. And every person that we meet, whatever their problems might be, who wouldn't you want to have a meaningful conversation with? Who wouldn't you want to introduce ideas to that could enhance their experience? And so it's been one of those age-old questions why some people are so responsive and can have surgery without a chemical anesthesia. They can literally have their bodies cut open surgically while having some procedure done to them without any anesthetic whatsoever. It's really highly responsive people, and others who are less responsive. But I'm always mindful of one of the great pioneers in the field of hypnosis was a psychiatrist named Milton Erickson, who used to say, if you can be socialized, you can be hypnotized. And I think that's probably in the realm of true. I wouldn't say it's absolutely true, but for most people, the ability to respond to some degree is present. Everyone is subject to influence. And then it's just a question of what parameters, who's viewed as credible enough to influence them. How much do they trust themselves enough to go along with the experience? When somebody says, oh, I don't think I can be hypnotized, that's not flattering to yourself. The people who are responsive, it's because they have really good focus. They can pay attention. It's because they're more flexible in their thinking. It's because they can suspend previous perceptions in order to engage with new possibilities. The advantages of being highly responsive are many. And so that's part of educating people that this isn't something that's going to take control over your mind. It's not something that's going to make you do something you don't want to do. It really is about being flexible enough to absorb new ways of thinking, new ways of responding, new ways of behaving. And in that respect, almost anybody's capable of a meaningful response.
I think
it's interesting.
I was just going to say on that, just in the realm of irritable bowel, we've done quite a bit of work on this as well, and this idea around what we call sort of predictors of response, who is more likely or less likely to respond, and we've done some really interesting studies where we've looked at what Michael describes as, your depth or your hypnotic susceptibility. And you can, like he sort of mentioned, you can measure this on various scales. But what we've found is that the depth of hypnotic susceptibility that any one individual has is not a predictor of how they're going to respond to the therapy. So if we have 80% of people who will respond in terms of a symptomatic response who present with irritable bowel, if we look at the 20% of people who haven't responded, they're not the ones that are less likely to be able to be hypnotized. They're not the ones that are less have a lower hypnotic susceptibility. So there's no correlation between the two, which I think is really interesting.
Yeah. That's really what I meant when I said the response to the test score doesn't predict clinical response. It's really different when you're running somebody through standardized testing as opposed to providing them with a personalized, tailored approach to their treatment. Even those 20% that you haven't been able to reach, we don't know how they would respond to other procedures.
Why do you think that is? Why do you think if people differ so much on their hypnotizability or their depth of hypnosis, why do you think that there's no difference in outcomes?
Not that there's no difference in outcomes, but the point is it's not the predictor of outcomes. And when we ask the question that you just asked, which is a great question that researchers have been wrestling with for literally the last full century, where people have been designing test after test to try to measure this abstract capacity for hypnotic responsiveness. And there are a number of factors that will influence people's capacity to respond, but this isn't by any means a full representation. Let's start with the things that have been ruled out. What about somebody's personality? Well, there hasn't been any data to suggest personality types are the determining factor. What about people's intelligence level? What about gender? What about mental status? What about? And so that still is one of the unanswered questions that people wrestle with. But when we look at what people can do, the people who are most responsive, some of those factors that I've already mentioned: capacity for absorption, imaginative ability to suspend engaging with the external environment, so-called reality testing, in order to be able to respond to suggested realities. That somebody can be sitting in my office in an office building in the middle of downtown San Diego, and I can start talking to them about being at the beach and hearing the sounds of the surf and smelling the salt air and hearing the sound of the seagulls and feeling the sun warming their skin. And they're sitting in an office, but if you measure their skin temperature goes up in response to the suggestion. Now that requires an ability to set aside the objective reality of where they are in order to be able to get absorbed in a more subjective reality, the suggested reality. And that capacity is really, I think, one of the most defining characteristics. You can do hypnosis without ever relaxing anybody. You can't do hypnosis without people having that quality of dissociation that allows them to separate themselves from objective realities in order to get internally absorbed in the suggestions you're providing.
I think the other point is, it's no different to any other therapy that we might provide, to a patient. For example, a low FODMAP diet. We know that 75% of people will respond to the low FODMAP diet, but what about those people who don't? Why don't they respond? Or what if we give, person drug A? 30% of people might respond to drug A, but why do the remaining people not respond? And so, I don't think that this is isolated to hypnosis. This is universal.
That's right. There's even a percentage of people who don't like chocolate.
Yeah.
What are you going to do?
Who are they? Who are these people?
I haven't met one, so I don't know. I am going to segue to talk more about mental health, because this is mental health awareness, and we could talk about hypnotizability all day, but I'm just going to move us in the direction of mental health. Because it's primary to your practice. Maybe, Michael, you can talk about how common mental health disorders are and what the most common conditions are.
Yeah, the data have changed radically in just the last 2.5 years because of COVID. When you look at the latest data, some of which were published just 3 days ago in the very prestigious medical journal called The Lancet, it shows that 1 in 8 people worldwide are suffering a diagnosable mental disorder. That number is even higher, 1 in 7, when you look at the age group of the 10 to 19-year-olds. When we look at the most common disorders that we're asked to treat, number 1 on the list is anxiety, and number 2 on the list is depression. And they can occur separately, but statistically, it's more common for them to coexist. And what are called comorbid conditions, a term that Simone was using earlier. Comorbidity, when 2 or more conditions coexist in the same person. And so the numbers increased pretty dramatically during the pandemic. and they've stayed there since then. And it really illustrates a point that I made quite a while ago. I have long been a critic of the use of antidepressant medications because the rationale for their use was never demonstrable, and now it has actually been disproven. The idea of thinking of depression as a result of a chemical imbalance has been pretty well torpedoed. And so, the idea that I wrote about in a book called Depression is Contagious years ago is that these are conditions that are socially defined, socially caused. And the COVID pandemic really proved that when you disrupted people's routines, when people were forced into social isolation, when people lost their jobs and faced economic hardships, when they didn't have care for their kids who were forced to stay home from school, and everything was just up in the air, not to mention the grief when you lost people to COVID. The numbers here in the United States far, far exceeded the numbers of dead in Australia and other parts of the world, but the numbers worldwide have been huge. So the point I'm making is that as world conditions change, as social conditions change, life experiences change, the vulnerability to mental health issues has increased and will continue to increase. What that tells us on a practical level is we can't drug these things into submission. There are all the things that we need people to be able to do drugs can't do alone. And I'm not saying you should never prescribe an antidepressant or an anti-anxiety drug, but to be realistic about it, medications are the most popular form of treatment, but they're extremely limited. They can't teach you new coping styles. They can't teach you new problem-solving styles. They can't build you a support network. They can't undo a history of trauma. They can't help you establish and work towards realistic goals. And these are the kinds of skills that people need to develop if they're going to handle life effectively. And that's really what this is about. If you ask me what mental health is, it's about adaptability. That what makes for human experience is constantly changing. The human experiences are constantly evolving as societies change, as technology takes over. Ways that we use technology now that were unthinkable even 10 years ago. The rise of social media, the studies that show how the more time you spend in front of a computer screen or on social media, the worse you're going to feel for all kinds of reasons that if we have time, we can talk about it. But so for me, what World Mental Health Day is about is a number of things. One, it means acknowledging the fact that people are struggling all over the world. Two, it's placing the recognition that these are changes arising for social and technological reasons. Three, it means having to lift the stigma so that people know how to get help and when to get help and where to get help. And that's what we most need the media to get behind. And fortunately, the media is getting behind it. More stories now that are being done on radio, on television. In fact, I'd like to give Simone a plug. She just did an interview for NPR, National Public Radio here in America, a very widely heard radio program. And she described beautifully what the NERVA program's about. And they even provided some samples of her processes, which sounded great. And that's what we need, that kind of mental health awareness, that these are problems that everybody has the potential to face. Who's vulnerable? If you're capable of moods, you're capable of a mood disorder. If you live in a body, you're capable of health problems. And so it's really important that we help people understand that this is something that has to be paid attention to, taken seriously. And if you want to really take it seriously, to be able to think in preventive terms. When I first started studying depression 50 years ago, there weren't any treatments available, and the idea of prevention was fantasy. Now, 50 years later, we have good treatments and we have good prevention strategies that have been tested, and proven reliable across a variety of contexts. So that's what it's about for me.
Thank you. Simone, maybe you can comment a little bit on what Dr. Yapko just spoke about, and then also talk a little bit about mental health in IBS patients, and maybe if you've seen the same changes that Dr. Yapko spoke about through the course of the COVID pandemic in your patients as well.
Yeah, look, I think Dr. Yapko put it very eloquently, and I don't think that there's sort of much more that I can add there. But I guess the reality is that unfortunately we are seeing more people present with mental health issues, and there's a variety of different reasons behind that. And I think we as healthcare providers need to be able to support these people through various means, and like Dr. Yapko mentioned, not just in terms of pharmaceutical options, but also in terms of behavioural-based therapies, hypnotherapy being an example of one of those, to help these patients to have better outcomes in terms of not only their mental health, but also their physical health, their sort of their minds and their bodies. And I guess when we think about the impact of mental health in people who present with physical complaints, we know that there is a huge overlap here. And if we're talking about irritable bowel syndrome as an example, we know that probably somewhere between 40 and 60% of patients who present with physical complaints will have some sort of psychological comorbidity. And again, primarily this includes disorders that are associated with anxiety and or depression. We also see a really notable trauma history association in patients who present with physical complaints. And so we have to be really mindful of this when we're managing people. And I guess when we determining what management strategies are the most appropriate. And, as a general rule, for example, we know that when we use hypnosis that we see favourable outcomes in terms of people's physical symptoms and also their psychological symptoms. But the primary aim of hypnosis, in terms of certainly what I do, is to manage that physical response. So providing that sort of direct suggestion to the subconscious part of the mind for the control and normalization of gut function. So the improvement in the physical symptoms. Now, again, you're not just a body, you're a mind and a body. And so if we make you feel better in your body, if we reduce these physical symptoms, logically, it makes sense that you're going to feel better in your mind. And we know that when we make people feel better physically, they also respond psychologically. So we see a reduction in levels of anxiety, a reduction in levels of depression, improvements in quality of life in patients who undergo something like hypnosis. But there are a percentage of people that even if we improve their physical symptoms using something like hypnotherapy, psychologically, they still need more support. It might still be that they meet the diagnostic criteria for a mental health disorder, or it might be that they don't and that they're just not coping as well as what they would like in terms of managing their mental health on a day-by-day basis. And those are the patients that need additional support through psychological-based therapy. And one of the psychological therapies that we most certainly use in our clinic is something called cognitive behavioural therapy, which has been shown in many, many, many different trials over lots of years to be really effective in terms of managing people's mental state.
And hypnosis is easily integrated with cognitive behavioral therapy as well as other therapeutic approaches. And in fact, right now I'm involved in a long-term research project dealing with long COVID patients, the people who have been infected with COVID who didn't recover after 2 or 3 weeks. And 6 months later, a year later, even 2 years later, they're suffering terribly with all kinds of physical symptoms and problems. And my piece of the research has been using hypnosis to reduce the physical symptoms as well as the levels of depression and anxiety associated with it. And the research project is not yet complete. Right now, it's about 2/3 of the way complete, but already we're seeing the benefits of including hypnosis and reducing the depression levels associated with the long-term infection symptoms. And that's what I'm really looking forward to developing for Mindset. In the coming months, we're going to be developing, based on some of this research as well as other experience, programs that are designed to promote mental health, especially to be able to better manage the symptoms and issues associated with depression. that are so common amongst people that even when depression isn't the primary problem, it's usually a secondary problem because people don't really feel good about whatever their problems are. So I'll be looking forward to developing that and integrating that into the mindset health programs.
I think also, without overcomplicating things too, some just really basic lifestyle changes can make profound differences to people's mental health or their mental well-being. So things like making sure that people are eating really good quality food. So eating, lots of different foods from, your 5 key food groups. So your fruits, your vegetables, your grains, your proteins, your dairies, and variety within each of those food groups. And there's been some really beautiful data that's been published by a group here in Melbourne at Deakin University, which has essentially shown that the poorer your diet quality, the more likely it is for you to experience mental health difficulties, so notably anxiety and depression. So that's something that people have the power to change on their own accord on a daily basis, is to make these really good quality decisions about how they fuel their bodies. Exercising, making sure that you're exercising and that you're keeping fit. Again, there's a plethora of data that shows that exercise promotes good mental health. Sleeping well. So, again, the fundamentals, making sure that you're getting adequate amount of good quality, uninterrupted sleep at night, and avoiding, large quantities of alcohol or sort of other drugs is, also really important. And I think these are often, this idea around managing one's mental health becomes overwhelming if you don't have immediate access to healthcare providers that can enable high levels of support. But there are things that you can do at a lifestyle level that have profound impacts on your ability to cope on a day-by-day basis.
Great point.
I have a question here that was submitted. And the question is about hypnotizability, going back to that just for a second, on whether hypnotizability is fixed or it's changeable in patients.
Well, it depends who you ask. One of the greatest hypnosis researchers was named Ernest Hilgard, who ran the famed Stanford University Hypnosis Research Lab. And Hilgard spent more than 30 years along with his associate, Andre Weitzenhofer. Both of them were mentors of mine. We've had a chance to talk about this exact issue many times directly. But Hilgard and Weitzenhofer were absolutely convinced that hypnotizability is a fixed trait, that it doesn't change over time. And then there are other researchers who have come to a very different conclusion. I'm in that camp, that hypnotizability is changeable. And I think that when you talk to people who have been working with hypnosis for a while, they see how people evolve a greater degree of responsiveness the more experience they have with it.
Awesome. Thank you. I am just going to transition over. I know we only have a few minutes left, so I'm going to ask some of my questions that I wrote down. What inspired both of you? I know we've talked a lot about the success of hypnotherapy, the success of the trials that have been run historically, and what prompted you to partner with Mindset Health and want to deliver app-based therapies? Because prior to this, most therapies have been delivered in person. So what's the research to suggest that app-based therapies are as effective, and what prompted you to get involved?
Okay, I'll jump in here first, perhaps. So I think, look, certainly in the space that I work in, it's a highly specialised space. There's trying to find somebody who is either a psychologist or has a psychology background who is interested in using hypnotherapy and is specializes in gut disorders is almost impossible to find, and so I suppose one of the biggest issues that we have around providing hypnotherapy to patients who present with gut disorders is accessibility. There's just not many people that provide this kind of therapy. And then secondary to that, it's affordability. Obviously, even if you have access to somebody who can provide you with this level of care, you need to often wait really long periods of time. And if I think about any of the services that are either publicly or privately run here, just in Australia, you're looking at waiting anywhere between 4 and 18 months to be seen, which is a huge amount of time for somebody who's really struggling physically and or mentally. And then, there's also the assumption that that person can afford to pay for the therapy, which a lot of people clearly can't. And so I think what really inspired me and motivated me to partner with Mindset Health was to make this really good quality, evidence-based therapy available to as many people as we absolutely could, to make it highly accessible and to deliver it in a way that is evidence-based and affordable. So you've probably gathered by now that I do like research and I do like data and I love numbers. And so, one of the really important things is, for me, was making sure that when we deliver something like hypnotherapy via an app, is it as effective as when we deliver it in person? Or is it as effective if we delivered it over the internet, or in whatever way it happens to be that we make the therapy accessible? And what we've found through looking at lots of different data is that, yes, hypnotherapy that is targeted toward improving gut symptoms in people who have irritable bowel is equally as beneficial if it's delivered via an app or if it's delivered in a face-to-face setting. So that's really reassuring. We know that people who listen to the app are going to respond just as well as what they would if they had access to a therapist. Now, one of the concerns around that, obviously, is that when you receive something via an app, it's kind of per protocol. It's the same for everybody, right? It's not individualised care. But interestingly, it's not individualised care when you're on a research trial either. Similarly, it's delivered per protocol. It's the same for each patient. And so we know that in terms of using hypnotherapy in people who present with irritable bowel, we know that about 75% of people respond really favourably, and the level of improvement that they achieve is similar to what we would expect for other therapies that have a really good quality evidence base. So something like a low FODMAP diet, say, for example. So I guess that's a really long-winded way of saying accessibility, affordability, large-scale delivery that we know works just as well as a face-to-face therapy, and that improvements are maintained in the long term. So I think that's another really key thing. We know that placebo responses are really notable in patients who present with irritable bowel. Probably 40% of patients with irritable bowel will feel better if you sit them in a room and talk about the weather, right? But those improvements aren't going to be maintained in the long term. So it might be useful for a day or for a week, but, the patient's going to come back after a week and say, well, hey, my symptoms have returned. But what we've been able to show with hypnotherapy is not only do we get people better, which is clearly the aim, but we keep people better. And the longest study that's been published in the literature has been, which essentially followed patients over a 5-year time period, and they showed that people who had responded to therapy had maintained those improvements in the long term. And we've done that now in face-to-face therapy settings, but we've also looked at this in app-delivered settings as well. And we know that people who respond maintain those improvements.
I think Simone said everything exactly right. The pandemic drove a lot of the research that when therapy had to go to telehealth because people couldn't do face-to-face sessions, the research question naturally arose. So what are we losing by not having face-to-face sessions? And as it turns out, we're not losing anything. That in some ways we're making gains, that people don't have to spend time traveling to a session, from a session, sitting in a waiting room for the session to begin, that it's more immediate, more effective. So we've learned that telehealth works. And then when we take it to the level of Mindset Health, it certainly emphasizes the affordability, the accessibility that Simone was talking about, but it also places a greater responsibility to recognize the need for self-help, that this is no longer now just about a therapist who's out there trying to fix you. It's about you working with yourself, you taking the material and proactively using it for your own benefit. So I think Chris and Alex, the founders of Mindset Health, were ahead of their time in even wanting to put this together. And I think they've done an admirable job with Mindset Health. And I think that it holds great potential as it keeps evolving to reach more and more people. And I think that is a good thing.
Awesome. We'll wrap up there. I know we're out of time. It's been an absolute pleasure listening to both of you. And we're so lucky to have you on the board at Mindset Health, and have your input in everything that we do here. And like you both mentioned, we'll continue bringing these products to as many people as we possibly can, and hopefully helping more and more people as we grow.
Great. Thanks, Claire, and thanks, Simone.
Thanks, Claire.
Thank you both.
Bye.
All right. Take care. Bye.